Welcome, everyone. Mastering acid-base physiology isn't just about passing exams. It's a critical, hands-on skill that can genuinely change outcomes at the bedside. In our world of anesthesiology and critical care, pretty much every single biochemical reaction, every drug's effectiveness hinges on a very precise hydrogen ion concentration. So in this masterclass, we're going to break down exactly how to navigate these complex challenges in your daily practice.
Here's our game plan. We'll start with the core principles, the body's first line of defense. Then we'll dive into the really elegant ways the respiratory and renal systems compensate. From there, we'll build a systematic diagnostic approach you can literally use on every single patient. We'll also look at the direct, practical implications for anesthesia, and then we'll wrap it all up by putting it together with a truly fascinating case study. All right, first things first, let's revisit the fundamental science. We need to refresh our understanding of why pH is so incredibly critical, and then take a close look at how the body's initial lines of defense, those buffer systems, spring into action almost instantly.
We talk about pH all the time, but it's so important to remember what it actually represents, the hydrogen ion concentration. And because that relationship is logarithmic, what looks like a small change in pH is actually a massive physiological event. For example, a drop from 7.4 to 7.1 isn't a small dip. It's a doubling of hydrogen ions. That's a huge shift that can wreak havoc on enzyme function and protein structures all over the body.
The body doesn't just have one trick up its sleeve. It has this beautifully coordinated, time-sensitive sequence of responses. Think of it like a multi-layered shield. The very instant a threat appears, chemical buffers absorb that initial shock. Then, within minutes, the lungs jump in for a rapid, though often incomplete, correction. And finally, the kidneys begin their slower but much more powerful work to definitively restore that delicate balance.
Now, here's where it gets really interesting. This slide highlights a critical distinction. The bicarbonate system, which is our most important extracellular buffer, is fantastic against metabolic acids. But, and this is a big but, it has a crucial weakness. It can't effectively buffer against an acidosis that's caused by its own component, CO2. Why? Well, adding CO2 just pushes that whole equilibrium reaction to the right, making more acid. Hemoglobin, on the other hand, is a true workhorse. It can buffer both metabolic and respiratory acid loads right there in the vascular space.
Okay, so with that foundation of immediate buffering in place, let's move on to the body's heavy lifters, the incredibly elegant compensatory systems of the lungs and the kidneys that get to work right after that initial response. These compensation roles are absolutely essential clinical tools. They let us predict what the body should be doing. In metabolic acidosis, central chemoreceptors kick into high gear, driving hyperventilation to blow off CO2. It's a fast and pretty predictable response. But take a look at metabolic alkalosis. That response is way less reliable. The drive to slow down breathing is limited because, well, the body won't let itself become dangerously hypoxic. So PaCO2 rarely rises above 55 mmHg as a compensatory move. And this table just brilliantly illustrates the huge difference between acute and chronic respiratory problems. In an acute situation, say sudden respiratory depression, the kidneys have absolutely no time to respond, and you'll see the bicarbonate level barely budge. But give it 3 to 5 days, and the kidneys mount this powerful response, significantly cranking up bicarbonate to buffer that chronic acidosis. This distinction is absolutely vital when you're interpreting an ABG in a patient with something like chronic lung disease.
So when faced with acidemia, the kidney launches this incredibly powerful three-pronged defense. First, it stops wasting bicarbonate. Every single molecule gets reabsorbed. Second, it starts actively getting rid of acid by binding hydrogen ions to urinary buffers, like phosphate. And in doing so, it actually creates new bicarbonate. And third, it ramps up ammonia production, which acts as a super effective urinary buffer, allowing for the excretion of a massive acid load in the form of ammonium. It's really quite brilliant.
Okay, theory is great, but how do we actually apply all this knowledge at the bedside? Well, let's build a rigorous framework you can use. A systematic approach is truly the only way to reliably navigate these complex acid-base scenarios, and, more importantly, avoid missing a hidden life-threatening disorder.
Following these 8 steps, in order, every single time, provides a critical safety net. Seriously, don't skip steps. We start with the pH, then check the respiratory and metabolic parts to find the main problem. But here's the crucial part. The real detective work happens next, when we check if the compensation is appropriate and when we calculate the anion gap. This is exactly where we uncover those tricky mixed disorders and really figure out what's going on. In metabolic acidosis, the anion gap is your best friend. It helps you differentiate between two fundamentally different processes. A high anion gap means a new acid, like lactic acid or ketones, has been added to the system. Think of it like this. The bicarb gets used up buffering it, but the anion from that acid is left behind, creating the gap. In contrast, a normal anion gap acidosis is usually caused by a direct loss of bicarb, and the body just retains more chloride to keep the electrical charges balanced.
This table right here is your bedrock, your fundamental reference. Just notice the pattern. For any primary disorder, the compensatory response always moves the other parameter in the same direction. A primary drop in bicarb is met with a compensatory drop in PaCO2. A primary rise in PaCO2 is met with a compensatory rise in bicarb. If you see them moving in opposite directions, a red flag should go up. You're almost certainly looking at a mixed disorder. And this takes our analysis one crucial step further. It's not enough to know the direction of the compensation. We have to know the magnitude. Is the body responding appropriately? By calculating the expected response and comparing it to your patient's actual labs, you can unmask a hidden second disorder. For instance, if your patient with metabolic acidosis has a PaCO2 that is way lower than expected, they don't just have an acidosis, they also have a primary respiratory alkalosis. This is step 6 of our protocol, and it's where sharp clinical diagnosis really happens.
So why do we, as anesthesiologists, need to be absolute masters of this? How does all this theory translate to the operating room? Let's get right into the direct implications for our anesthetic management, because this is where these numbers become critical determinants of patient safety. Severe acidemia is a systemic crisis, plain and simple. It's like poison to the heart muscle, making it weak. It causes vasodilation, dropping the blood pressure. And here's the real kicker. It makes the heart and blood vessels resistant to our vasopressors. You can be pouring in pressors and nothing happens. At the same time, hydrogen ions are shifting into cells in exchange for potassium, leading to a dangerous rise in serum potassium that puts the patient at huge risk for fatal arrhythmias. This slide right here is exactly why we're having this conversation. A pre-op ABG isn't just another number. It fundamentally changes our entire anesthetic plan. In an acidotic patient, our anesthetic agents become way more potent cardiovascular depressants. Opioids cross the blood-brain barrier more easily. And using succinylcholine when there's acidemia-induced hyperkalemia, you are absolutely playing with fire. And don't think alkalosis is benign either. It can constrict cerebral arteries, risking brain ischemia, and set the stage for life-threatening arrhythmias if potassium is low. Now, when you do need to use alkali therapy, which is usually when the pH drops below 7.20, this formula gives you a reasonable starting point. But the goal is not to normalize the pH completely. That can actually be dangerous. The goal is just to get the patient out of that critical range. That's why the guideline is so clear. Give half the calculated dose, then stop, and reevaluate with another ABG. It has to be a measured, cautious approach. All right, to wrap things up, let's synthesize everything we've covered by tackling a challenging real-world case. This is going to put our systematic approach to the ultimate test and really show its power in a complex, messy clinical scenario. So picture this. You've got a very sick 1-month-old infant. He's post-op, and now he's in florid congestive heart failure, showing all the signs of shock. The team does the right thing. They intubate him to support his breathing, and they draw the initial set of labs. But what comes back is a clinical paradox that could so easily be misinterpreted. So, you get the lab report. The first number you see is the pH, 7.47. Okay, alkalemia, right? You might even feel a little relieved. But then, your eyes drop down to the base deficit, minus 14.6. And the anion gap, a staggering 32. And your stomach just drops. Both of those numbers are screaming that there is a severe, life-threatening, high anion gap metabolic acidosis going on, probably from lactic acid due to his shock. The respiratory alkalosis is just so extreme that it has overcompensated and dragged the pH into the alkalemic range. So how on earth is this even possible? Well, this is the classic presentation of a mixed disorder, where one process is completely masking the severity of another. It's a physiological tug-of-war. If you only looked at the pH, you would be dangerously reassured. But the base deficit and the anion gap, they tell the true scary story. This is precisely why that systematic approach is so essential. It prevents a catastrophic misdiagnosis. And just when you think you've got it figured out, the story gets even crazier. The team treats the heart failure with diuretics. Now look at the labs. The anion gap is still high, meaning the lactic acidosis hasn't gone away. But look at the bicarbonate. It's jumped up to 18. That makes absolutely no sense with an ongoing acidosis. The reason? The diuretics have now induced a third disorder, a contraction metabolic alkalosis. This iatrogenic problem is now further masking the severity of the underlying acidosis, creating this incredibly treacherous triple disorder.
This case proves, beyond a shadow of a doubt, that the pH value is only the beginning of the story. It's just the net result of all the underlying processes, and it can be profoundly misleading. The true clinical picture and the key to actually managing these patients effectively lies in that systematic analysis of every single component, allowing you to see the individual disorders that are hidden just beneath the surface.